So, fungal diseases. Fungal diseases in the previous, if we see our history, fungal diseases were reported more commonly. So, the fungal disease affects the skin, the scalp, the nails. These were most common. But let us study the fungal or the mycotic infections concerning the oral region. So, the mycotic infections of oral cavity, among them candidiasis is the commonest and most commonly seen, or the opportunistic fungal infection. So, along with candidiasis, we are going to study about the histoplasmosis, the blastomycosis, coccidioidomycosis, aspergillosis. So, these are all the commonest fungal infections. And we are also going to study the one protozoal infection which is occurring and more commonly seen with symptoms in oral cavity, that is the toxoplasmosis. Okay. So these infections, or the fungal infections, they are caused by few funguses. Each infection is caused by a different type of fungus. The study of all of the fungal diseases is known as mycology. So candidiasis, also known as candidosis or moniliasis or thrush. It is caused by a yeast-like fungus, that is the Candida albicans. Not only the Candida albicans, there are other species, other different species of Candida which cause this candidiasis. Okay, candidiasis, Candida albicans, actually it's a normal inhabitant of the oral cavity, gastrointestinal tract, and the vaginal tract. So these three places normally they show presence of the Candida. Candida albicans, it exists in three forms: the pseudo hyphae form, the mycelial form, and the fungal form. Candida, as we know that it is the normal inhabitant. So when does it develop? The infection develops. The infection develops when the organism spreads deeper into the tissues. There is penetration by the organism into the tissues that leads to manifestations of the disease. Just the presence of organism is not responsible for causing the disease. Invasion or penetration by the Candida albicans is causing the disease. So what are the predisposing factors for development of candidiasis? Candidiasis, it occurs when the individual may be immunocompromised. The individual may have acute diseases like the leukemia. The individual may be prolonged hospitalized. He may be in hospital suffering from some debilitating disease. The immunocompromised host, like the affected with HIV virus, and presence of iron deficiency, anemias, or nutritional deficiencies, and presence of debilitating diseases like the diabetes mellitus. All these make the host weak. And whenever there is prolonged hospitalization or prolonged use of antibiotics, even the normal flora, normal inhibitory flora, they become suppressed. So in that way, it predisposes for the development of candidiasis. And few forms of candidiasis, they are specifically associated with wearing of dentures. So the area becomes the area whichever you are wearing the denture, that shows hyperplasia or inflammation. So that way it predisposes to development of candidiasis because of trauma, we can see. So these are the local and systemic factors which leads to development of candidiasis, which predisposes the individual to candidiasis. So the candidal infection, it has been classified by variety of classifications. We'll see the candidal classification based on its nature: acute and chronic candidiasis. Acute candidiasis, there are two forms of acute candidiasis. There is the acute pseudomembranous and the acute atrophic candidiasis. Chronic forms, we can see the chronic hyperplastic candidiasis, also known as candidal leukoplekiac form. Then, and there are many group of symptoms together constitute the chronic mucocutaneous candidiasis. And the other is a chronic atrophic oral candidiasis. So we'll study each of them in detail. Acute pseudomembranous candidiasis, basically it's seen in infants, or it develops before the age of 5 years, It is more commonest form of the disease, the pseudomembranous form. It's also known as thrush. The clinical appearance of the lesion is the appearance of soft, white, elevated plaques on the buccal mucosa, tongue, gingiva, or palate. Any site on the oral cavity shows the development of this plaques. The plaques, they actually resemble milk curds. So these milk curds, they are removable or they are scrapable from the oral mucosa. So once they are removed, they just leave an erythematous mucosa on the surface. These are not that painful. Acute pseudomembranous form is not that painful. And whenever the you see the acute pseudomembranous candidiasis in infants, you should make a presumptive diagnosis that the individual is suffering from some chronic illness. The individual is immunocompromised individual. So these plaques are asymptomatic. They do not cause any pain to the patient or any form of discomfort, and they are usually just scrapable from the oral mucosa. That is the acute pseudomembranous candidiasis. The acute atrophic candidiasis, it is also known as antibiotic sore mouth because it has been associated with the development of candidiasis on prolonged usage of broad spectrum antibiotics. So whenever the individual uses broad spectrum antibiotics for a prolonged period of time, then he is more prone to develop this acute atrophic candidiasis, also known as erythematous candidiasis. So as the name suggests, here the clinical appearance of lesion is not that of whitish color elevated plaque as seen in pseudomembranous. Here the lesion appears as reddish in color or erythematous in nature. There will be macules which are just situated on the oral mucosa, buccal mucosa, tongue, gingiva, anyway. Specifically, when this acute atrophic candidiasis occurs on the tongue, it's known as the central papillary atrophy of tongue or the median rhomboid glossitis. It's actually a developmental anomaly or developmental disturbance seen. In this area, what happens is the posterior aspect of the tongue, it shows the loss of filiform papillae. The rhomboid shaped area, it shows the loss of filiform papillae, and that region is painful, and it shows this erythematous candidiasis. It is extremely painful lesion. Pseudomembranous was not painful, but erythematous candidiasis is painful in nature. So that's about the acute forms. Now we'll study the chronic forms of candidiasis. The chronic forms, the chronic hyperplastic candidiasis is more common. It's also known as candidal leukoplakia. It has been more commonly associated with human immunodeficiency virus. So the appearance of candidal infection along with leukoplakic infection, it gives a clinical appearance of like that. Here the appearance of clinical appearance is one of elevated plaques situated on the lateral border of tongue or buccal mucosa. These are not scrapable. They appear like leukoplakic-like lesions which are not scrapable. So hence they give, and microscopically when you see the picture, you see the appearance of epithelial hyperplasia, acanthosis, as you can see in leukoplakia. And you can even demonstrate the presence of fungal organism, that is the Candida albicans. Hyphae of the organisms are seen. So mixed picture of candidal infection and leukoplakic infection gives the diagnosis of this chronic hyperplastic candidiasis. Firm white persistent plaques appear which are not scrapable from the buccal mucosa. So next we'll see the chronic mucocutaneous candidiasis. Actually the chronic mucocutaneous candidiasis, it's a group of syndromes. It shows the candidal infection of the skin, scalp, nails and even the oral cavity, that is the mucous membrane. The chronic mucocutaneous candidiasis may occur in the familial form, that is transmitted from one generation to other generation, or a local form may be restricted to one particular area, or a chronic diffuse mucocutaneous candidiasis. So whatever be the familial form, the familial forms, it is seen in younger age individuals before 5 years of age, and they are transmitted as autosomal recessive inheritance. So the chronic familial mucocutaneous candidiasis, is the candidal involvement of the skin along with the mucous membrane, and it is transmitted to the next generation also. So the appearance of this transmitted disease shows that the immunocompromised nature or character is being passed from one generation to other. The cell mediated immunity basically is affected here. And the chronic localized mucocutaneous candidiasis, here there is no genetic transmission, and the chronic localized is a more severe form of the chronic candidiasis. Along with the candidal involvement of oral cavity, you can see granulomatous and horny masses on the face and the scalp. So whenever granulomatous infection occurs, it gives a more aggravated or severe form of the candidal infection, which are non-escapable, which are painful in origin. So all these are about the chronic localized. Chronic diffuse mucocutaneous candidiasis. As we have seen that candidal infection occurring in younger individuals or children, this diffuse mucocutaneous candidiasis, it is seen in older age individuals, that is above 55 years of age, and there is no genetic transmission. Here the candidal infection occurs involving sheets of tissues, that is they involve the limbs, groin, face, scalp, shoulders, all show severe granulomatous infection, that is extensive plaques may be seen in all the sites, that is the skin, groin, face, scalp, and even the mouth and nails also. Other chronic form of candidiasis is the candidiasis endocrinopathy syndrome. Here, along with the occurrence of candidiasis in the oral cavity, along with the clinical picture of oral cavity candidiasis, you can see candidal infection of the skin, scalp, nails, and mucous membrane. These are eventually associated with, along with candidal infection, endocrine diseases like hypothyroidism, hypoparathyroidism, Addison's disease, all are frequently encountered as systemic diseases along with the candidal infections. So that gives the name candidal endocrinopathy syndrome. When coming to oral cavity, the elevated plaques are seen on the buccal mucosa, tongue, gingiva. Along with that, even the enamel hypoplasia is seen. So basically the defect, there is a disturbance in endocrine system, so it affects the teeth also. The teeth show enamel hypoplasia. So that is all about the acute and the chronic forms of candidiasis. Sometimes the candidal infection, whenever the candidiasis occurs, the patient shows hypersensitive reaction to it in the form of manifestation like rashes, vesicular eruptions, or maculopapular rashes develop in the patient. That is nothing but hypersensitivity to candidal antigen. It's also known as id reaction. So patients who already have chronic forms of candidiasis, they may show this hypersensitivity, and that is known as the id reaction. So how do you diagnose a candidal infection? Demonstration of the candidal hyphae on the cytologic smear. The elevated plaque, whatever it is scrapable, you scrape the lesion and you just send it for cytologic smear. So when you see microscopically the hyphae are present, it gives the diagnosis of candidiasis. The hyphae are characteristically seen in cases of periodic acid stain. So this stain that demonstrates the hyphae correctly. And one more test is the rapid diagnostic test. Here the cytologic smear, it is just smeared with potassium hydroxide solution. What this potassium hydroxide does is, it lyses the background of all the epithelial cells present. So only the yeast and the hyphae may be seen. It gives a more clear picture of the Candida albicans. So treatment for forms of candidiasis is symptomatic treatment. Along with symptomatic treatment, antifungal drugs have to be given, like the nystatin, the amphotericin B, and iconazole. Both topical applications of antifungals, topical applications actually result in better treatment options. Actually, topical applications, what happens is the organism it's just destructed there. And systemic ingestion of the drugs also heals the disease. So that's about the major opportunistic infection, that is the candidial infection or the candidosis infection. So we'll see the less common mycotic infections of oral cavity. So there is histoplasmosis. Histoplasmosis, it's a fungal infection caused by Histoplasma capsulatum microorganism. Here it's also known by other name like Darling's disease, because the Histoplasma capsulatum, the organism, it has a special predilection or liking for the reticuloendothelial system. So the organism, it just inhabits or infects the liver, spleen and lymph nodes. So characteristic clinical picture of these three systems affected may be seen. So that's why the name is given as Darling's disease. So clinically, when you see symptoms, systemic symptoms like fever, cough, hepatosplenomegaly, hepatosplenomegaly, splenomegaly, anemia, leukopenia, all these give a picture of dissemination of the microorganisms to the systems, that is the reticuloendothelial system. And you can even see the histoplasmin skin reaction, that is the appearance of subcutaneous nodules on the skin. In severe cases, when the lungs are involved, you can see calcified pulmonary nodules on the skin. Actually, the transmission of virus from transmission of fungal infection from one individual to another occurs through inhalation of spores of the fungus. This inhalation of occurs either through dust or through excretion of the birds like the pigeon or the blackbirds. They just leads to dissemination of spores in the air, and then that when that dust is inhaled by the individual, you get the disease. Oral cavity, when you see especially skin, you have subcutaneous nodules. Like that, in oral cavity, ulcerative or nodular lesions of the palate, gingiva or buccal mucosa or tongue may be seen. So the characteristic of these histoplasmic infections is that after the nodules ulcerate and they try to heal, there is a brownish crust formed because of desquamation of the cells. That brownish crust is on the lips is more common, and you can see in the clinical picture also the lip is showing a brownish crust there. How do you diagnose the histoplasmosis condition? Is the clinical features show both the liver, spleen, kidneys and the lymphocytes being affected. Along with that, you can just demonstrate the presence of histoplasma capsulatum organism when you take a cytologic smear from the affected site. These organisms are predominantly found in the phagocytic cells. They may be just about 1 mm in diameter, like that. Treatment has to be based on the clinical appearances seen. Mostly they resolve on its own, the histoplasmosis infection. Blastomycosis. Blastomycosis is a fungal infection caused by organism Blastomyces dermatitis. Actually, this disease, it occurs in two different forms, like South American blastomycosis and North American blastomycosis. The division is not based upon the occurrence or geographic distribution, but the North American blastomycosis, the microorganisms, whatever are demonstrated, they are smaller in size, like about 10 to 15 microns. Whereas the South American blastomycosis form is caused by a different species of blastomycosis, and the microorganisms, when seen histologically, they are about 10 to 60 microns in diameter. So the difference in size and species of microorganism gives the name. This Gilchrist disease is the North American blastomycosis form. The infection occurs from unknown sources. The etiological agent is not known. The organism is the Blastomyces dermatitis, and it has been reported that the individuals who suffer from this disease were working for a great deal of time outside. They were working in outdoor areas. So some related thing that outdoor work inhalation of some form of spores might have occurred, some dust or spores might have occurred. This blastomycosis disease is seen in cases of middle-aged individuals and more predilection for occurrence in men's, associated with the thing that they are more commonly seen in people who work outdoors, of occupational exposure, working in outdoor areas. So initially the lesion appears as it is seen in the form of red papules on the surface of skin, which eventually develop into miliary abscesses or sinus tracts, demonstrating presence of abscess or pustules, which eventually ulcerate and heal. And along with this, the cutaneous lesion, whatever is seen, it's indurated with elevated borders. So in the clinical picture, you can see the papillar kind of a lesion is seen there here in the clinical picture. So the infection spreads from the subcutaneous tissues through the bloodstream, and widespread dissemination occurs, and systemic features like fever, cough, myalgia, headache are common. And when you see the oral cavity of the affected individual, you see the presence of tiny ulcers. These ulcers may give a picture of actinomycotic ulcers. They just very small in diameter, and they just heal by themselves, ulcers. And microscopic diagnosis is through demonstration of blastomyces dermatitis organism. The connective tissue, it shows inflammation and presence of gained cells, presence of lymphocytes, macrophages, and microabscesses are more commonly seen. Epithelioid cells may also be seen sometimes. So that's with the blastomycosis North American form. The South American blastomycosis form, as I told you, it has characteristic feature that the microscopic picture shows that the organisms are about 10 to 60 microns in diameter, and painful gingival ulcerations are seen here. So, and the portal of entry, the source of entry is also through the periodontal structures. Along with the periodontal lesions, you can see lymphadenopathy. The association of periodontal lesions along with lymphadenopathy is characteristic for the South American form of blastomycosis. So treatment is just symptomatic treatment, that's it, because these lesions, they heal by themselves, or sometimes antibiotic treatment is also carried out, or antifungal treatment like amphotericin B is given. Because of the granulomatous infection occurring, mostly the antibiotic treatment and the antifungal treatment are indicated. Next, we'll study the coccidioidomycosis. Coccidioidomycosis, it is caused by the organism Coccidioides immitis. The characteristic appearance of this disease, it's also known as valley fever, sand joint valley fever. Here the transmission from one individual to other occurs through inhalation of dust containing the spores of the organism. Actually, the reproduction of this Coccidioides immitis, it develops in the form of arthrospores or spirules. These spirules are about 10 microns in diameter, and they contain the smaller sized endospores. So whenever the spirules are ruptured, they release the smaller endospores, and these endospores spread through airborne, and then they are causing the disease. So clinical symptoms, clinical features of respiratory disease may be seen. There are two forms of coccidioidomycosis, that is the disseminated form and the non-disseminated form. The non-disseminated form, it primarily shows features of the respiratory infection, that is the cough, pleural plain, headache, anorexia, nausea may be seen. Along with the presence of this respiratory infection, the skin lesions in the form of erythema nodosum or nodular lesions of the skin are seen. This disease, the disseminated non-disseminated form, it's self-limiting. It resolves on its own within 10 to 14 days. The disseminated form, it shows that the spirules or the endospores, whatever are present, they spread from the lungs to a variety of other systems like the bones, joints, liver, spleen, central nervous system. So disseminated form is a severe form of the disease by this coccidioids immitis. So when you see a clinical picture of the nodular lesion or the erythema nodosum, whatever we are seeing, when you see a clinical picture, the clinical appearance is one of a granulomatous infection. So you can see mononuclear cells, phagocytes, lymphocytes, and even the gained cells showing multinucleation. So all these is a clinical appearance of a chronic granulomatous infection. Inflammatory cell infiltrate is also seen. Treatment for this, you can see the histologic picture that a gained cell is being seen in the middle. The pink color one, that is the eosinophilic one, that's a gained cell which is multinucleated. And that's nothing but the, it shows the picture of this coccidioids immitis. Treatment for the disseminated form is fulminating one. It has effect on almost all of the systems. So amphotericin B is started initially to rule out the, to destroy the fungal organism. Like that. So the other lesser common forms of fungal infections or the mycotic infections is the aspergillosis. Aspergillosis, it's a mycotic infection caused by Aspergillus species. Clinical appearance of aspergillosis infection may be of two forms. There is the invasive form and non-invasive form. The division of invasive and non-invasive is based on the fact that the microorganisms, they either affect the normal host, that is the non-invasive form, or they may affect the immunocompromised host. Based on that form, it has been given as the invasive and non-invasive form, and they penetrate the tissues also to greater extent, the invasive forms. So the when the aspergillosis disease, it occurs in the normal host or the immunocompetent host, it affects the allergic sinuses related of the oral cavity, and you can see that the mass of fungal hyphae, they just get deposited in the maxillary sinus, as the name given is aspergilloma. Aspergilloma is just a mass of fungal hyphae seen in the sinus. And when you see the immunocompromised individual shows widespread manifestations of the disease, like the occurrence of chest pain, cough, fever. Then the infection even spreads to the central nervous system, eye, skin, and liver. So already the individual is immunocompromised, and the organism Aspergillus, it's invading all over the tissues. So more severe clinical manifestations are seen. When coming to the oral cavity, just the painful gingival ulcerations are seen. They may be erythematous, surrounded by halo, and they are exudative in nature. Microscopically, demonstration of septate hyphae. These Aspergillus species, they have a specific predilection that they occur or they invade the blood vessels. They are seen around the blood vessels. So the demonstration of hyphae in association with the blood vessels gives a picture of this aspergillosis form. Small ulcers may be seen in the oral mucosa, with just surrounded by an erythematous area, and even the yellowish fibrin exudate is also present. Then there is we have seen all the 5 mycotic infections of oral cavity. So the mycotic infections, diagnosis of all of the mycotic infections is through cytologic smear or staining of the scraping of the lesion. The stain demonstrates the organism, and when the organism is demonstrated, particular antifungal drug given just eliminates the disease. We have although protozoal organisms, whatever are causing disease, they are not that severe, but there is a specific disease which is called the toxoplasmosis. It is caused by the organism Toxoplasmosis gondii. It is a protozoal organism. It shows widespread effects on the oral cavity. So the only protozoal organism which shows like fulminating effects on the oral cavity or oral lesion is the Toxoplasma gondii. Here the infection, initially it is just asymptomatic infection, the toxoplasmosis. It enters the human body through inhalation of dust containing the organism. Mostly everybody has come in contact with the Toxoplasma gondii, because the normal inhabitants of Toxoplasma gondii is the cat. So the cat shows the reproduction, the sexual reproduction of this protozoal microorganism. So once it reproduces, it just stays in the gut of the cat, gastrointestinal tract of the cat, and it is excreted through fetus. When the humans come in contact with the excreta of cat, then the microorganism enters the human body and it starts the infective stage. So the human being and just get the disease through the cats. So once the disease starts, it's asymptomatic, and then there's development of low grade fever along with characteristic cervical lymphadenopathy. The lymph nodes are enlarged here. In severe cases, the disease spreads to the central nervous system through the lymphatic spread. So you can see necrotizing encephalitis and even respiratory infection like pneumonia is seen. The congenital toxoplasmosis, that is, if the individual, the infant at birth, if it acquires the protozoal organism, you can see severe defects of blindness and mental retardation. So clinical picture is like non-specific because it's like it has been associated with variety of clinical symptoms, like it affects the central nervous system, the respiratory system. So clinical picture is a little bit non-specific in nature. So histologic picture of the lymph node specifically, because characteristic if lymphadenopathy is characteristic of this organism. So when you see section of a lymph node in the microscope, you see reactive germinal centers are present. These reactive germinal centers show accumulation of a lot of macrophages, denoting inflammation occurring, chronic inflammation occurring there. So care has to be taken for proper prevention from the spread of the disease, preventing ourselves from contracting the infection through our own cats, our own animals. So this toxoplasma, it has a life cycle in the animals, that is the cats, and then from that it spreads to the human being. So that's about the fungal and the only the commonest protozoal infection, that is the toxoplasmosis.